Okay, so this is part 2 on hemiplegia. Hemiplegia is a partially paralyzed one side of somebody's body after they've had a stroke. A lot of you probably saw it over the summer. You see it once, you never forget it. Kind of figure out what it is in your head before you see it. It can be challenging, but you will see a lot of this. You will see a lot of this in hospital, acute rehab settings. You will see a lot of this in nursing homes. You'll see a lot of this even in outpatient facilities. It's very, very common. OTs are working around this all the time, and especially around the hemiplegic shoulders. It really impacts ADLs, that sort of stuff. When you're working with somebody with a hemiplegic shoulder, think of those general neuro principles. You want to drive that neuroplasticity, which is the neural growth and change of those brain cells, which facilitates recovery. Repetition without repetition. What does this mean? Definitely repetition is a great thing to drive neuroplasticity and neural cell growth. But if you want to vary it up, don't make it too boring. Kind of goes down to this one, doing things the person cares about, which is kind of basic OT stuff. The more meaningful you can make it, the more varied you can make it, the more challenging you can make it, that just right kind of challenge, the better for clients for driving neuroplasticity. Cardio is also big. Get their heart rate up, get them on a treadmill or something. It's really, really good. A good warm-up, a good driver of neuroplasticity that they're finding more and more is cardio. Combining the upper extremity and the lower extremity in treatment. Neurologically, you can't separate the upper extremity from the lower extremity. And they're going to want to do this to you the second you go into the hospital and clinic. PT does the lower body, OT does the upper body. Body doesn't know this little rule about who does what. The way the body works is all together, as we kind of been showing, all these full body movements, especially with strokes, especially with neuro. Think of children. When we treat children, we don't separate so much. We treat the whole body. You need to really think about treating the whole body with the upper extremity, and I'll talk more about what I mean by that. Progress through constant challenge mistakes. Allow them to mess up. Invite them to lose their balance. Push, push, push. Have them stumbling around, making mistakes. That's how they kind of drive this plasticity, drive the change by being challenged, not making it too safe, too easy. Hemiplegia and subluxation. This is a great image of subluxation. What is it? Somebody's had a stroke. In a lot of cases, the muscles within their shoulder that we've been learning about, especially the deltoid, rotator cuff muscles, become paralyzed, atrophied. They no longer are working. And the shoulder is pretty heavy. I don't know if it's heavy as the head, but it's pretty heavy, so it just sags. It just starts to come right out of the socket. This one's pretty bad, or sometimes it's pretty subtle, but it's just kind of sagging out of that socket. That's what kind of subluxation is. If you see that, and usually it's in the chart, but sometimes it isn't, you have to kind of assess. We'll show you how to assess, determine if this is the case. There's certain precautions, things you want to keep in mind, that you don't make this shoulder worse and cause them all kinds of awful pain. And no overhead motions, no fast, especially any kind of fast movement. Really be really careful about above shoulder movements. If you're doing that, make sure you're facilitating that scapula, making sure scapula is protracting and gliding with them as they go overhead. Stretch from a closed chain position, hand on surface. That's what I mean by closed chain. If your hand is on the surface as they're stretching and doing stuff, you can go from a flexed elbow to an extended elbow. Think of it on a desk or something. Vary the height of the surface. You can do it on a therapy ball. Roll the therapy ball out as they come back and forth, extending and flexing their elbow, fixed on the therapy ball. Can load arm, bear weight, and closed chain. So the affected arm, let's say it's a left hemi, the left arm would be bearing the weight as you do something with the right hand. So they could lean onto the left, wash a table down, dust a table, do something with their non-affected right hand. So they're loading on the affected side, we're saying it's the left side, and doing a task with their right side, their non-affected side. Kinesiotaping, we're going to do that in the lab this week, week 5. It's a great way to kind of pull it back into place up there. Some of you did that over the summer. Kinesiotaping for hemiplegia, it's subluxation, very, very common. E-stimulation, E-stim, NES. It's amazing. You hook up these wires, little electrodes to the shoulder, and boom, pops it right into place. The evidence how long it lasts is not conclusive, but it definitely facilitates. It's felt good for doing exercise and activity. You can do the E-stim, get the shoulder back in place, and do more stuff, be a little more aggressive. Slings, this is a Give Mohar sling. I like it because it's not putting him into the classic elbow flexed impingement position. It keeps it more free so they can kind of get some bouncing in there. Slings in general, not good news for shoulders or even hemiplegic shoulders, but it is heavy and it can protect it. It does have a role, especially when you're out and about in the community, walking around a lot. The sulcus sign, this will help you determine if they have some kind of subluxation. If it's not obvious, the degree of subluxation. So with this, it's very, very simple. He's stabilizing up here on the acromion, and then down here, distal humerus. He's just pulling it down slightly, gently. How much play is there in this shoulder joint? How much is it coming down in the glenohumeral joint? And then compare it to the good side. We can do this on each other. I think we'll have time to do this in the lab this week. It's a good way to kind of determine, is it subluxed? Is it an issue? Is it not? And then usually they measure the degree of subluxation in fingers. That's like 2, maybe even 3 fingers subluxation. You can measure it in inches, get a little measuring tape as well. So you can see if a lot of times as the stroke recovers, as they regain use of their shoulders, it goes away in some cases. So that's the sulcus sign. It's in general treatment principles around hemiplegia. Again, aerobics are great. Stretching out muscle imbalances within the body. If one side is partially paralyzed or even fully paralyzed, generally speaking, this is very generally, bicep can get shortened. The pecs, as we know, can get very tightened, especially if they're in that kind of rounded position. It's more of a PT, but the plantar soleus in the back of their foot can get tight. The mirror is a great thing a lot of OTs use. They can see themselves in the mirror, correct their posture, get good trunk control, have good kind of movements. Pushing and pulling in general are really good for getting to engaging the scapula. And a lot of times you're trying to work on protracting and retracting that scapula. That's kind of where you start in a lot of cases with these shoulders, because that is paralyzed or weakened as well. We talked about combining the upper and lower body together. Very support. Ways of kind of combining upper and lower body together. Just think about getting the person up. It may take 2 of you to do this. It's a great thing to do with a PT. Getting the person up, maybe closed chain with their affected arms, maybe they're weight bearing onto their dresser or something with one hand, and then the other hand is doing something as they're standing and shifting back and forth. So it's the upper and lower body all working at the same time versus just sitting in a chair and doing something, or sitting on the edge of the bed and doing something. Very support, even if it's a chair, very support in the chair. Go to softer support, T-ball, so it's more dynamic underneath them. And then standing up statically, and then weight shifting. When they're up, move towards that. High to low surfaces as they're reaching with that arm, putting dishes away, doing tasks with the arm. Engaging the affected arm, different things, carrying things against their side, just holding something in the crook of their arm, even their pocketbook. Think about holding things with both arms. It's usually there's things like right in front of you that they need to do if you're in a hospital setting. Grabbing that walker. Just work on grabbing the walker back and forth. Support bars, carrying items, laundry, washing dishes. Great bilateral tasks. Vary the task. Different walking services, different tasks. Talking while doing, the dual tasking. Doing tasks as they're doing visual scanning. Really keep challenging them with different neurological components, neurological challenges, that sort of thing. Okay, so I'm going to go